this is crazy. It's supposed to be healthcare. And it was just mind-boggling.
There's such a great opportunity to lead in this space.
Find a partner that meets your needs.
Put yourself in the patient's shoes.
And when patients understand, patients are happy.
Organizations that succeed in this are going to be the ones that bring in RCM.
We're always looking for chances to do better.
The problem in our industry is
Hey, everybody. Welcome back to another episode. This is our Vendor Voices series. We're nearing in on the holidays here, and dare I say, we have a gift. Today, that gift comes in the form of Keith Eggert, COO of Abax Health. Keith, we start off every Vendor Voices episode with the Snapshot Challenge. Are you ready?
I am ready. Let's go.
All right. Question number 1. Who is Abax Health?
So Abax Health really is totally in the patient access space, and we are a company built by operators for operators.
All right. Question number 2. Who does Abax Health serve?
So because of our model of tech-enabled services, we actually span from very large academic, non-academic integrated delivery systems, all the way to critical access hospitals and multi-specialty clinics. So we span ASCs, the whole thing. So we're very, very large, and all the way down to, as I said, critical access hospital.
All right. Question number 3. What problem is Abax Health solving?
So we're really focused on connecting patients with the care that they should receive when they need it. That's really part of our vision. Patient access is a critical component to the front end of any healthcare organization. And so we bring to the table a operator's perspective of best practice in everything that we look at and touch.
All right. Question number 4. How is Abax Health solving that problem?
So part of our component is, attaching and identifying lost revenue that has leaked through the healthcare system. And leakage is a terrible word, but it is what it is from that perspective. So the focus is on identifying referrals that never got scheduled in the first place. And it's not something anybody did wrong. The reality is there's a referral. You tried to contact the patient 3 times because that's all you can do because of the inbound new volume. Unsuccessful in doing that, the referral goes into a black hole. So part of what we do is to unearth that information, bring it to the surface, and work on reattaching those patients to their respective healthcare delivery organization and re-engage them into both the healthcare process and, of course, attaching that additional net revenue into that organization.
All right. Final question. How is Abax Health solving that problem differently?
So our business model, first and foremost, we are a tech-enabled services company. So we are using our tech in the way of, contact, outreach, all of those components to engage with the prospective patient, based on the open referral. Our delivery model is unique from the perspective of dedicated team members to our respective customers. We don't cross customer bases across our team members. So it's a very, what I would say, a white glove dedicated service to where, our team members are, working in the EHR of the respective client, depending on what we are doing for that client. But everything takes place within the respective EHR, which puts us, depending on the product and what we're working on, we're a complement to the existing staff and process. Or in other instances, if we're talking Abax 360, we are rebadging employees and taking over the whole component. But 100% of what we do is we operate as that client. We actually don't operate as Abax Health.
All right. You did it. Just shy of a minute to spare.
There we go.
Snapshot challenge over. We can relax a little bit. First, yeah,
Yeah.
we did it. We did it. Check. The world now knows more about Abax Health.
Exactly.
But we'd like to know more about Keith as well. So Keith, why don't you tell our listeners about you?
Sure. So currently, as Ryan indicated, I'm Chief Operating Officer for Abax Health. I'm coming from a unique perspective to where I've spent about 90% of my career on the provider side. And this is my second foray in a revenue cycle startup. First one being very successful. This one on a very strong track to success. As I step back, I joined Abax Health about almost 2 years ago now, leaving the University of Miami healthcare system. So I was, a VP of revenue cycle for all things patient service net revenue generation at the university's health system. Prior to that, helped launch a startup called VisitQuate, very well known in the industry now. And prior to that, I was the vice president of revenue management at Orlando Health. So I've, as I said, pretty unique perspective of always having had patient access in my area of responsibility. Quite honestly, I started in patient access at Orlando Health back in the day, called Orlando Regional Medical Center. So it's always been near and dear to my operations, and for Abax Health to be 100% in the patient access space, it is really kind of a cool place to be at this point.
Full circle there, huh?
Yeah.
Yeah. So I'm really excited to have this conversation. I want to hear a little bit more about that transition. What was that like, moving from the provider side to the vendor side? What maybe shocking conclusions did you come to, or any big surprises?
I will tell you, it was an eye opener. When I first did it, it was good almost 10 years ago. I have my peers, I've known my peers around the country forever. And now you're on the other side of the door, so to speak, and you don't quite get the response that you got as colleagues, which is great. You have to learn how to navigate around that. And you really do learn, the respective leaders' personalities and processes, et cetera. The biggest eye opener was the length of time it takes to get through, whether it's supply chain or contracting, as you're doing a deal, going to stand up a new product. It took a lot longer in a lot of organizations than I had ever anticipated, and that was probably the biggest eye opener. So, and then of course, don't be pushed back, so to speak, and be depressed about you're not getting a call back or whatever's happening. It's life. So, from that perspective.
Yeah, I haven't been. I don't even like to say I'm in sales so much as I'm in just the business of helping people. But I know what you mean. That was a big learning curve for me not so long ago either. Just, it's not you necessarily, right? These are
right. Now,
these are busy
cycle,
people.
I don't care if you're selling services, you're selling technology, you're selling tech and services. It's all a very long sales cycle. So, yeah. But you just got to be used to that. You got to be, you learn that, and you work with it. That's how it works. That's how it goes.
Why do you think that is? Why do you think this cycle's so long?
Again, from the unique perspective, bureaucracy is a very harsh word, but I would say the regimented processes within a large healthcare organization around, first of all, you've got data security, then you've got compliance, then you've got, the overall, contracting component, and there's many, many little, areas that have to all come into alignment in order for that to even, a scope of work or an MSA to get to the point of being ready for signature. And, how providers are busy. They're providing healthcare services. Their cash is king. Get the cash in the door, because that's number one. So when it comes to having time for this side project or this, this new vendor solution, which is really, really important and can generate a lot of revenue for the organization. They've got to focus over here because that cash has to come in the door. And when they have time, push this other process through. So, and I get that because that was my life forever and ever is cash is king, customer service, patient experience, cash, and, away you go. So,
Yeah, I've done some interim leadership roles, so not nearly to the extent that you've been on the provider side. I will never sit here and say I've actually fully been in those shoes, but I've gotten glimpses of it, and I, for what it's worth, would echo everything you're saying. I mean, the main thing simply is time and resource, right? You got
yeah.
a day job, and you're chipping away at that, and you know that you want, what Keith's bringing, right?
Yep.
But you got to find the time to do it. And then all those, let's call them guide rails and compliance checklists, they're
Right.
there
Which,
for a
which are all
reason.
very important and serve a critical
Exactly.
purpose in the process. And that's why I like new people that are, coming in especially on the business development sales side. It's like, I try to help them and go, look, it's not you. This is how this process works. Would we love it to be different? Absolutely. But at the end of the day, you got to jump through these hoops because those hoops are important. But some hoops are closer to each other in some organizations and some hoops are farther apart, depending on how, how flowy the organization is internally and how efficient. So, yeah, I
Yep.
mean, it is what it is, I guess, at the end of the day.
Yeah, absolutely. And before we click record, you and I had a brief combo on AI, and
Mhm.
it's interesting because I hope in some ways that AI can help decrease that time with some of the more administrative tasks that maybe we can
I
leverage
would
AI
agree with
for.
that. I would agree with that.
But on the flip side, compliance around AI and making sure that, you're bringing, if it's an AI product or service that you're bringing in, right? Bringing that into your organization, that needs to be watched very, very, very closely. And
Absolutely.
so that could end up just taking all the time that you saved
Yeah, it's
here.
like you're
Now
gonna
it's,
save it. It's like you shrink it over here, and now it just ballooned over here because of the risk and different things like that. So yeah,
yeah.
and that is the
And
beauty, you know, um, that is the beauty of our industry. And it doesn't matter if you're trying to collect money from a payer or register a patient, whatever the situation is, or what you just described. I call it whack-a-mole because you resolve one
uh-huh.
thing, you trim one thing, great, this is perfect. Now you got another mole popping up over here, and it's something you didn't even anticipate, or there shouldn't be. So I refer to, and anybody who's worked with me knows that revenue cycles like whack-a-mole. You just keep going.
Oh yeah.
So
Yeah,
yep.
I've heard that. I don't think you're alone there. I think that's probably pretty common phrase in revenue cycle. This show was brought to you by Real Partners Consulting, a free to provider vendor selection support company. We help healthcare providers find the right revenue cycle partners across technology, consulting, and managed services at no cost to you. If you like what you've heard from today's guest, or if you're looking for any other partner in the revenue cycle space, let us do the heavy lifting for you. Reach out to me, your host, Ryan Downs, on LinkedIn or at rdowns@realpartnersconsulting.com, and I will personally help you find the right fit. Now let's get back to the episode. So I want to lean in a little bit to your unique experience because I don't know how many folks I'll get uh, with that split background. So I'm gonna task something that I think will be really really interesting to our audience here. First, we put the provider hat back on, go back in time.
Mhm.
Now, having seen it from both sides, how can vendors be better business partners to their providers?
So, and I'm going to start the answer to that with how I operated on the provider side. Because in my eyes, there wasn't a vendor provider relationship. I mean, I never wanted to approach that because it's more of a partnership. Okay. So our relationship is a partnership, and a partnership goes both ways. And, what can a vendor learn? A vendor needs to learn that they are a true partner, which means you bring the bad information with the good information. We collaborate, same way with the provider, and together we lift whatever process or service that, that's being delivered. I never ever, treated a vendor like a vendor, so to speak, they're just a vendor. No, that was never. And that I was really happy I didn't do that, especially on my first foray on the non-provider side, because, I didn't realize I actually did it to the extent that I did until I got onto the vendor side. So
Yeah, I think that's great advice. I am biased, but I literally named my company Real Partners
there you go.
with the intent to bring that forward. But I do say vendor, and I say vendor voices just because, I don't mean to bring a negative connotation towards it. It just is a definition, right? It just is a word. But at the end of the day, yes, becoming a partner instead of maybe what's labeled as a vendor, I think is absolutely where everybody should
Yeah,
strive to
it's not
go.
just service or whatever that's being provided. I mean, it's an alignment to achieve a certain goal that requires everybody to be on the same page.
Yeah, I talk with a lot of vendor partners, whatever you want to call them, and every once in a while they'll be like, "Hey, Ryan, do you know anything about XYZ? We got somebody asking about it." And the first thing I always say is, you should feel like that is flattering and that is a compliment to you that you're doing so well for your provider partners that they're asking you to do something you don't even do.
Exactly. That's
Like
exactly
that's a
right.
partnership,
Yeah, that is a
right?
partnership. Exactly.
So I always love to hear that. Um, so now flip side, and maybe it ends up just being the same answer. So vendors be partners, right? I
Yep.
think is the takeaway there. Um, if we put uh, the vendor hat on and now look at, hey, when you now in the vendor seat, what is something you wish providers did a little bit differently or paid a little more attention to?
Um, so in some instances, I do see some dismissiveness on the provider side of their, I'm going to call them partners. And because they're focused over here to deliver, cash is king, even though it might be a partner that's focused on bringing cash in the door, that primary focus over here kind of almost negates the priority of what should be coming in the way of opportunities, issues from that partnership. So, and it's a delicate balance to make sure that gets the same priority as your internal ops. Because at the end of the day, they're both in the scenario I'm talking about, they're both pumping cash into the organization. And, so, sometimes if it's not under your direct control, you're not as worried about, the performance and the output, but I don't agree with that. I think it's an extension of it's a partnership. It's the extension of your internal operation.
Yeah. I'm curious if I'm understanding this in the same way that I've come across it in it. Um, with a lot of organizations, your provider partner and your vendor partner have already come to the conclusion that together we can bring an ROI that
Hmm.
everyone's happy about. And even once you've gotten to that stage, I think this is maybe what you're getting at, right? But I can't stop my day to day. And I get so caught up in my day to day that even though I know this is going to help my day to day, takes time and effort to get that across the finish line.
Correct.
And that's a really tough balance, I
Yeah.
think. And
In my leadership structures in revenue cycle, I always had a role of a partnership leader, um, which others call vendor management. But not from the perspective, are the invoices getting paid and all that? No, from the optimization perspective, knowing how this partnership plugs into internal ops to achieve the goal, and then how do we grow it? I mean, from the perspective of more performance, I mean, if that's more volume, whatever the situation might be based on the services being provided, I actually had to have a senior, direct report to me that was engaged at that level to understand what services were being provided and how to improve that, both internal things improve to help support them and make them more successful, and vice versa. So, but if you don't have that focus on it, then it becomes, well, that's the vendor that's handling it. And that's not how you hit the high levels of success.
Yeah. No, very glad to hear this. I hope our listeners agree, or for those who haven't thought of it this way, start to shift. I mean, it's critical, and not just in revenue
Yes.
cycle, but anywhere and in any relationship.
Right.
Um,
Absolutely. And there's a lot
so
of big outsourcing deals and small outsourcing deals and plug and play across the industry. So it's not like our industry is becoming more in-house based. It's more partnership and best practice based, and moving components into different environments where they're more efficient, more accurate, and in a better cost structure.
yeah, I don't see outsourcing or vendor partnerships going backwards in any way. Maybe for the really large organizations who can build in-house more with AI and build entire teams and structures around that. But for the most part, yeah, I think there's more a need than ever with how expensive labor is.
Yes.
And anyway, so let's talk about patient access, right? Because
Okay.
that's what Abax is all about. That's what you're focused on now. Um, Broadly speaking, as we close out, I know we're not posting this right away, but as we close out 2025, what have you seen in patient access in 2025? And then after that, maybe give us a look ahead. What do you
Okay.
expect to see in 26?
Sure. So, and I'm just going to back up a little bit further back than that. Patient access has always been, and I've never agreed with it. In some organizations, it's like, well, those are the clerks that arrive the patient. Okay, that term makes my blood pressure go through the roof. Okay, your most critical point to get something right is in the patient access area. If you don't do it correctly, you're going to rework it, and it's going to cost you 5 times more if you're successful at getting the train back on the track and actually getting, the result that you needed to get, whether it was the payment or whatever the situation is. I've always been of the mindset, heavily invest in the front doors to make sure your scheduling is great, both from a patient engagement perspective and accuracy. Financial clearance is done, and you're actually financial clearing the CPTs of what's really going to happen to the patient, and not something that somebody ordered and they already changed it. So it's accurate financial clearance. And then, of course, the whole arrival of the patient, helping them on the financial counseling side to understand their benefits and what's owed. And so there are no financial surprises. You got to do the key pieces correctly, because then it flows right on through the revenue cycle, and boom, in comes your payment for the most part, unless you got some funky payer thing going on, which happens, but that's part of
No,
our industry.
never.
That's a
No.
whack-a-mole. That's a mole. Those moles pop up.
Yeah. At the end of the day, when you're doing that root cause analysis and you're playing whack-a-mole and you're figuring out why things didn't get paid on the back end, it all comes to the front, right? And I think
Correct.
it's now commonly understood that cleaning up things from the revenue cycle up front is what's actually going to have the biggest preventative impact on things like denials.
Mhm.
And also what I've talked to a few other guests about too, and outside of the podcast, engaging, and you, I think at the beginning mentioned the word re-engaging patients for what I would call kind of the lifetime value of that patient. Not to make
Correct.
it all about numbers, but I think that it benefits a patient to be able to get their care in the same place over and
Correct.
over as well. So it's not just about the money, but for this, context, we'll call it the lifetime value. If you don't like that, if you don't have a good initial experience with that person at the front desk, you might
Yeah.
lose that patient from the start. And that's not only, again, a financial failure, long term and short term, but we're not doing our job and our mission to take care of patients and the betterment of their
Correct.
health.
And I'm pretty big stickler on this. Patient experience is not just clinical. Okay. Patient experience, yes, it includes the clinical outcome, the clinical delivery system, but it also includes the financial delivery system.
Uh-huh.
So, if that front process is not being done correctly, and that bill goes out the door to the incorrect payer, the patient knows it and starts talking about the billing problems and how they can bill my services correctly. therefore diminishing the credibility of what's actually happening there, right, wrong, or indifferent. So again, if you do it right, have the right insurance at the right priority, all validated as it moves through that cycle, you have a great intake experience. Now you have a great billing experience for the mid-cycle component. And unless something derails on the back, it will close out and it will have been a good experience throughout the cycle. But there are critical failure points all over that cycle that you need to be on top of to make sure that you don't have a big issue.
Oh, absolutely. Yeah.
Mhm.
So what we're coming back to 2025, main themes, maybe some of those critical points that you're seeing.
Sadly, some things in our industry haven't changed a whole lot, over a couple decades. So, some of the in 2025, we have the benefit of the payer portals, and being able to do some automated authorization, even though a lot of it is still manual. We're starting to overcome, both with AI and with other solutions, some of those roadblocks that traditionally made things so manual and arduous. So that's really been the fight. That's why 2025 has been very interesting as some of the AI companies are coming out and things like that. 2026, I see as a perfecting year with a major uninsured patient population issue. Because depending on what happens at the end of 2025, if the subsidies aren't renewed on the health exchange side, that's going to drive a lot of coverage to the point of patients not being able to afford their coverage, which is going to leave them without health insurance coverage, which is going to leave them as an uninsured patient, to where now your patient access resources, coming through, patients coming through the emergency room, or they're coming in as a stat or whatever the situation is, or an urgent. Now your patient access team has to focus again on, how do we find some sort of financial assistance for this patient or stabilization for this patient, so that there is a solution to the financial side of it. So I see a shifting as an industry, depending on what component of patient access you're plugged into. But if you're plugged into the inpatient admissions, observation admissions, things coming through the ED, what's happening on the exchange side is going to have a dramatic impact. So that the resource focus has to be ready for it.
Yeah. I think everything you just mentioned is not only specific to patient access, but that's largely how I would define 25. I think we said a few of these words multiple times already. AI is really starting to get adopted. I'd like to see it get adopted even more safely. Um, and labor challenges, we've talked about it a few different ways. And yeah, I mean, the introduction of the One Big Beautiful Bill, OBBBA, HR, whatever you want to call it.
OB3, I've heard many different
yeah.
references.
We've seen it. We're seeing it now, and again, we're filming this in December 2025. We may know more by the time it gets posted, but really, a lot of the outcomes from that are going to start in 26, or the impacts of it. And to your point, it's a there's no reason to even try and argue that we're not going to have less insured people. That's
Exactly.
just
unless
a
something
fact.
changes and there's an extension, which would then kick it into 2027 or whatever the situation is. It's very volatile. It's very volatile. And, healthcare
Sure.
organizations need to be, especially their patient access areas, need to be on top of it. And leadership associated need to be on top of it. So that's it. We bring that to the table too.
All right, let's touch on a couple more things, and then we'll kind of round it out. We always like to get a little bit, not a little bit, a lot educational. I think we have been. I want to get a little deeper on that and talk metrics a little bit. So, I guess just very simply put, for our patient access leaders that are listening, or maybe those who just don't know much about patient access but should, what are the core KPIs that we should be keeping an eye on?
So, and as you mentioned earlier, some patient access areas are under revenue cycle, and under patient access areas, some scheduling centers are associated with patient access. So I make that
Sure.
delineation because if you are overseeing all of patient access, which includes the scheduling, whether it's existing patient, new patient, the whole thing, you're going to incorporate contact center statistics in those KPIs because you got to be on top of how your agents are performing, how long they're on, what's their quality, as they're doing the whole scheduling component. I had the pleasure of serving on HFMA's national KPI committee for 4 years. I chaired it the final year when we developed the KPIs for the industry that are now known as the MAP keys. And so, yes, so there's a couple of those key components. I mean, when you're looking at a patient access organization, your scheduling occupancy rate, or fill rate, so that is how many patients are getting scheduled in against your open templates. So that count, where is that ratio? That's a key one. Then also your first available appointment, for a subspecialty, monitoring that to make sure that you're opening capacity if possible to keep up with the demand. Okay. Those are some that are outside a little bit. Your authorization rate, your pre-registration rate, your insurance verification rate. Those are core to anything you do. I don't care if you're a dental office, you're a ASC, you're a physician practice, you're a large integrated delivery system or a hospital. Those are key because that dictates how the rest of your revenue cycle is going to flow based on that.
Yeah.
Depending on what function you are in the upfront patient access operation and what you're trying to track, there are pretty much KPIs for everything, like percentage of copays and deductibles collected prior to or at the time of service. There are great ones out there. So,
I'm talking to the right guy then. That's great. Yeah, those three core ones are the ones that come to mind for me. It's the pre-reg, the IV, the auth. But what stood out to me in the conversations that I've had with Abax and looking into you guys and is really that there's that added focus on referrals and scheduling, which you talked
Absolutely.
about.
Absolutely.
Yeah.
I've yet to see, I mean, certain EHRs are more sophisticated than others, but even in the most sophisticated EHR, I've yet to see great tracking around referrals. From that
I agree.
perspective. So that's what our Abax Insight tool does. It really kind of brings a transparency into what's happening, with the referrals, including the statistics and the monitoring and some of that. Because it's like, all right, great, we have a referral. Do we engage the patient? Did we get a hold of them? We didn't. And again, as I described earlier, when you have a flow coming in and you can only do so many a day based with your resources, the byproduct of if a patient doesn't willingly try to engage with you, boom. Or as a delivery person, if your scheduling center is at like normal business hours, well, if I need to schedule something, I'm going to be in the car driving home and I'm going to want to call somebody and get that scheduled because I don't have time during the day. And, I had a similar issue. I know our whole company was founded based on our CEO's experience with his colonoscopy order. I had the same exact experience in my own healthcare system down in Miami, and I'm almost ashamed to say it because, I got my referral for my colonoscopy. The scheduling center, the GI center called me. Every time they called, they said, could you call me after 5? I'm in meetings. I can't, could you call me after 5? Well, after 3 calls of, could you call me after 5? I never heard from him again. So 10 months went by before I remembered. It's like, oh, you know what? I never got that done. So, and it's just a bad model.
Yeah, I've heard, this is a common saying nowadays, right? But I've heard meet the patient where they are or, any version of that a million times. And I hear it a lot on collections.
Right.
And I hear it quite a bit on things like virtual patient care as opposed to in-person. Maybe I'm just not as privy to it because I'm not around it as much. I don't feel like I hear it quite as much. on scheduling. I think I'm hearing it more there, but I feel like it took a little bit longer. Collections, it's been there for a while now, right? Do I text?
Right.
Do I email? Do I call? Do I do it after business hours, to your point?
Correct.
Um, but I'm glad to hear that's kind of coming around on the scheduling side too.
Mm.
At the end of the day, scheduling is up to the patient, right? We can't just schedule
Correct.
on their behalf. We have to
Correct.
we reuse the words engage and re-engage. And I think you just mentioned some great things there, but maybe recap that or
Sure.
bring anything else. So that what are some things with or without ABAX, right, that health systems can be doing to make sure that their patients actually do schedule their appointments, both for financial reasons, but again, most importantly,
Right.
and always most importantly, for their healthcare.
So a couple components, and this applies whether you're an organization that does scheduling and then chases financial clearance, or you're an organization that does financial clearance, then contacts the patient to schedule. Okay. So, the most important component of it all is you have to get creative on getting a hold of the patient. If you don't have the basic, integration of texting to say, hi Keith, I'm, from so-and-so organization following up with you on your referral, um, you're behind the eight ball because I mean, dual authentication is hitting your phone when you're trying to get to a website. So, you need to be up to speed and implementing some of the tools that allow you to contact the patient in non-conventional ways. Of course, you should also be paying attention to what is the preferred contact method that the patient gave you, in the original build of their record, so to speak. If they've never been there before, you don't know that, obviously. But, if their preferred engagement is through, or preferred contact is through email, then you should be sending them an email or regarding this referral and going to their preferred pathway, same way as that preferred language. I mean, things have to align based on the data points that we know in order to expedite and improve the success rate of getting patients, from a referral to a scheduled event and getting them cleared into the organization. So, and finding out why patients aren't engaged or engaging is just as important as engaging them from an operator's perspective, because then you start to compartmentalize. Well, is it a out-of-pocket payment issue to why the patient doesn't want to schedule because they can't afford it? Is it a payer driving them to some other location as to why they won't schedule? Or is it, at the end of the day, I didn't like my provider and I don't want to go back. So those are critical elements for the operations to know of the organization in order to know what to improve so that it doesn't become repetitive and you just continue with more volume going down those pathways. So,
Yeah. Easy to forget that last part there, finding out why things aren't always going so well, and learning from that, right? We do that
and being
on the
able to
back end, but
see in a transparent fashion what is not engaging. I mean, meaning that those referrals that are going into a black hole.
yeah.
Not a lot of organizations have a view into that.
Well said, Keith. I think that's a good way to kind of close out our set of questions here. But as we do with every guest, I want to give you the opportunity. Any final parting advice that you have? Uh, what do you want our listeners to walk away knowing?
So I would say, and this is one of the things I've always done, is put yourself in the patient's shoes and go through your process. And, be a mystery shopper. And when you find things that are less than opportune, tackle them, take care of it. Patient should always be center, and then everything that happens is around that patient. So, but be the patient yourself. If you haven't experienced your own processes that you're leading and managing, that's not a recipe for success, in my opinion. So,
Super well said. Great advice, Keith. Thank you so much for being on the podcast. I hope you enjoyed it. I know our listeners did. Have an awesome rest of the day, and until next time.
Absolutely.
That's a wrap on yet another episode of Vendor Voices. Huge thanks to our guests for their insights and to you for listening. If this episode gave you something to think about, share it with your team. If you'd like to suggest a specific topic or guest, feel free to reach out to me on LinkedIn or at rdowns@realpartnersconsulting.com. Please rate and review, and be sure to subscribe to never miss an episode. I'm Ryan Downs. Thanks for tuning in.